Good morning, everyone. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. I'm really delighted that our department can continue to bring you these sessions together with the Ontario College of Family Physicians. And I'm going to turn it over to their president right now, Liz Muggah, for an introduction. Liz?
Good morning, everyone. So happy to have you all joining us today. We've got a terrific panel with Dr. Upton Allen and Sophia Ikura and colleagues. So really going to be a great session. This is MainPro accredited. Details are there and will be sent to you. I will read the land acknowledgement. So we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories that we're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I am calling in from Ottawa, so I'm seated Anishinaabe and Algonquin territory.
Thanks, Liz. Just drawing attention, there's been some incredible work done to try and vaccinate our Indigenous populations, particularly in the rural areas, and we featured some of that on our community of practice early on. But unfortunately, there's still a huge gap in vaccination among eligible Indigenous people living in urban areas, including in Toronto, where my colleague Janet Smiley has done a lot of work to really highlight this issue and also, advocate for community-led solutions. So if you've missed this article, it is worth a read because it's an important group that we still need to support during our last mile vaccination. Next slide. We've been pleased to bring you these series every 2 weeks, and just a reminder that all of our past sessions are available online, including the slide deck and a Q&A that goes along with it. They are MainPro accredited, and I bring this up now because our session today is going to really be focused on children age 5 to 11. I know many of you have other questions, for example, questions around testing or boosters, and we've covered those material in previous sessions. So please do check out our previous sessions if you find your questions hadn't been answered today. Next slide. I'm delighted to introduce our panelists to you today. Next slide. I'm going to begin by asking Upton Allen to introduce himself.
Good morning. It's a pleasure to be with you this morning. I'm Upton Allen. I'm head of infectious diseases at Sick Kids, a professor at the University of Toronto. This slide shows my disclosures, which are largely related to research grant funding, which comes to the institution as opposed to the individual. Thank you.
Thanks, Upton. Sophia?
Hi, I'm Sophia Ikura. I'm the Executive Director of Health Common Solutions Lab, a health innovation lab based out of Sinai Health System. I am pleased to be joining you this morning and sharing what we've learned from parents in some recent focus groups, and to declare my my conflicts of interest. We are in receipt of two grants from the Public Health Agency of Canada.
Nolan?
Hi, I'm Nolan D'Souza. I'm a community lead and project manager with Sophie at Health Common Solution Lab. In terms of disclosures, there are several listed here. The one I'll just point out is I'm on the board of directors for Wellfort Community Health Services, and through that role, I'm a liaison with the Alliance for Healthy Communities.
Excellent. Liz?
So family doctor from Ottawa and currently the president of the Ontario College of Family Physicians, and I receive a stipend for that role, and I don't have other conflicts to declare.
I'm Tara Kiran. I am a funded researcher, so receive salary support and grants from a number of organizations, as well as had some honorarium for speaking. The only one from a for-profit company was Gilead Sciences, which was on some work for hepatitis C. Next slide. We're delighted to welcome all of you from across Ontario. So lots in the GTA, but from many regions across Ontario as well. And what makes this community of practice shine really is your interaction Next slide. So just a reminder that we want to get your questions answered. So please put them into the Q&A. Please put your questions in the Q&A and then vote for the ones you like with a thumbs up. We will be prioritizing the ones that come to the top because they've been voted highest. So if you see someone else has asked a question that's similar to what you want to ask, instead of putting it in yourself, vote with the thumbs up. Also take a moment to look at the answered section in case that's already been answered. I'll mention that usually we have a number of people behind the scenes answering a lot of the questions by typing. There may be a little bit less of that this session, but we still do our best to get to as many questions as possible. The chat is a great way for you to react, share resources, connect with other people. So definitely use the chat for networking, but put your questions in the Q&A. Next slide. I just want to start off by congratulating everybody who's on the call today, because you've all played an incredibly important role in getting us to where we are today, which is 85% of our eligible population being fully vaccinated. So congratulations. We've been on this journey since mid-December, so almost a year now, and you have a lot to be proud of. We do know, though, that next slide, we do know that part of the, as a result of all of those great efforts, we have seen a real decline in cases and hospitalizations, even though we have now pretty much opened up to many of the normal activities. So, we can really look to vaccination as one of the many tools that have allowed us to keep our case counts low. That in our, I think, very judicious, slow reopening plan. But we know that there is a group that continues to be vulnerable and where COVID continues to spread, and that is, of course, in children aged 5 to 11. Next slide. And it's terrific to have seen that just a few days ago in the United States, the CDC went forward with recommending that children aged 5 to 11 can go ahead and get the Pfizer vaccine. Now, this vaccine is still under review for children here in Canada, and I think all of us are hoping that in the next few weeks it will be authorized for use. But we all want to know more about the vaccine so that we can prepare for giving it to our children aged 5 to 11. Next slide. What's also good news is that many parents seem now ready to get their kids vaccinated. So recent polling has suggested that up to 70% of parents are saying yes, they'll get their child 5 to 11 vaccinated. And another about 20% are unsure. So it means like they have questions that we as family doctors can help to answer to hopefully shift their opinion. Next slide. Some of the reasons that they say they want to get their child vaccinated is to protect their child from COVID, to protect their other family members or household members, including other young children who haven't been vaccinated, as well as older vulnerable adults who they know haven't fully built up the immune response from vaccination. They want to prevent their child from missing in-person school, and they want to feel more comfortable about taking their children to public places. So these are all reasons, that parents have already that resonate with them, that we can articulate to other parents who might be on the fence. Next slide. At the same time, there are a number of concerns that parents who don't want their child vaccinated at this time have. So, many people who are on the fence, are saying, there's a lack of research, the vaccine hasn't been out for long, they're worried about the side effects for their kids, myocarditis, some people are saying fertility, the rest of the family's already vaccinated, they say, so really, is it necessary for my child to be vaccinated? They have a perception that kids, COVID is not severe in kids, and so that's leading them to think that the kid doesn't need to get vaccinated. There is this perception by some that kids will get longer immunity if they were infected rather than if they got the vaccine. Some people don't want to make a decision on behalf of their kids. So based on polling data, this is some of the reasons that parents have put forward for why they're hesitant to get their child vaccinated. And my hope is that at the end of today's session, that many of you feel comfortable actually addressing these questions and concerns with your with the parents of children in your practice or those parents that you're going to be encountering in vaccination settings. Next slide. So without further ado, I'm going to turn it over to Dr. Upton Allen, who's going to really take us through the science of the vaccine and help to get us ready to answer some of these questions.
Thank you very much, Tara. We might move to the next slide. Vaccination is all about balancing benefits against risks. And I recognize how challenging it is for you because you're on the front line and people come in and they come in with questions and you're going to have to address them. And I always say to families, it's about benefits versus risks. And as far as the 5 to 11 age group is concerned, and the COVID vaccines, based on what we currently know, benefits clearly overwhelmingly outweigh risks. Now, if you move to the next slide, I'm going to try to focus on the issues that relate to benefits and to risks. Now, in a broad way, one can see on the left-hand side the potential benefits, the impact of the vaccines on illness prevention at an individual level. So, for example, acute illness, the multisystem inflammatory syndrome in children, long COVID, and we can get into those in more detail during the Q&A. And then, of course, the impact on disease transmission, so that kids could live a healthy life that sees them functioning in the school environment and reducing transmission within the home and contributing to COVID control within the community. So on the benefit side, there are a number of key elements, and we can certainly go into those in more detail. And then on the risk side, yes, there's pericarditis, myocarditis, as Stars alluded to. And those are real signals, and we have to address them. But let me move to the next slide to show you some of the data that the FDA used to make a decision, and Health Canada is currently looking at. The first point is that when they looked at the neutralizing antibody titers that were elicited by 2 doses of the 30 microgram Pfizer vaccine, one found that the titers that the 5 to 11 experience using the 10 microgram dose was equivalent to what was seen at a higher dose in older individuals. So that was the first key point. That is, 10 micrograms in the 5 to 11 really seemed to work as far as generating neutralizing antibody titers. The second point, the second bullet point, was that there's also evidence of neutralizing antibody titers directed at Delta. And the third key point is that in the efficacy analysis, the vaccine was about 90% efficacious. And if you move to the next slide, you can see this, this data where there were about 1,300 children, 5 to 11, in the active vaccine group at 10 microgram. And then there's a placebo group. And you can see the number of cases prevented by the vaccine and relative to the number of cases occurring in the placebo group, with an overall vaccine efficacy of about 90%, the lower bound of about 68%, and the upper bound of 98%. If you move to the next slide, you'll see the demographic characteristics of the 5 to 11 age group who were studied in this analysis. And basically, you can see the companies and in the clinical trials are making more of an effort to ensure that the demographics reflect the populations where the vaccines are going to be used. It's still not a perfect world, that's for sure, but you can see approximately 6% Black African American in the Pfizer active vaccine arm, and in placebo, about 7%. And you can see the breakdown by ethnicity with Hispanic, Latino Americans, Asians, and the white population. So they're trying to make an effort to address concerns regarding underrepresentation among certain ethno-racial groups. So if you move to the next slide, it comes the issue of safety. So on one hand, we've seen the efficacy data, we've seen where the immunogenicity data came from. What about safety? The safety analysis is still ongoing, but they looked at just over 3,000 children, and no serious safety signals have been seen so far. It's still early days, but no serious safety signals have been seen so far. But if you look more at the safety in more detail, the next slide, it shows the events, the local reactogenicity that occurred within 7 days after each dose in the earlier phase 1 study among the 5 to less than 12-year-old. And as you can see, the group that got 10 micrograms had less redness and swelling compared with the group that got 30 micrograms. Pain at the injection site, the differences were not major between 10 and 30, but again, towards the lower end with the 10 micrograms. So this was showing that a 10 microgram was associated with less reactogenicity at the local level, and then coupled with the neutralizing antibody titers that I showed you earlier. And then going back to the next slide, or going forward to the next slide, looks at systemic reactions. And again, the same trend where the 10 microgram was associated with less systemic reactions. So in summary then, essentially what FDA looked at were data that showed that the 10 microgram appeared to be safer as it relates to reactogenicity, and generated neutralizing antibody titers that were equivalent to the higher dose. So therefore, you'd want to use that in the 5 to 11 age group. So if you move to the next slide. Now, what about myocarditis? And this is the signal that is real, and it is of concern, and we have to monitor this. If you look at the rates of childhood myocarditis generally pre-COVID, what we know is that rates tend to increase with age through the childhood age range. So here are data from Finland, 2004, 2018. And as you can see, the 15, 13-year-olds have higher rates of myocarditis compared with the younger kids. It appears that the rates of myocarditis associated with the mRNA vaccines mirror this type of graph. And if you look at the data from Ontario, on the next slide, generated by ICIS, that looks at the mean rates of myocarditis and pericarditis prior to COVID, it mirrors what you saw with the Finland data, increase in myocarditis rates as individuals got older. So this is for myocarditis and pericarditis combined, and thanks to Jeff Kwong and Sharifa Nazreen for providing this from ICIS. And next slide, you can see the breakdown based on just myocarditis. Again, increasing as the individuals got older, and then it settled out. Pericarditis, again, on the next slide, you'll see the same type of trend, and increasing with age. So what this is really saying, the flip side of that, is that as individuals move from the age group of above 12 to less than 12, one would expect the myocarditis signal to get weaker. And that's a really important point in the messaging and the discussions that you should have with families. So the next slide then brings it all together. So we know that the myocarditis, pericarditis is higher following the second dose of the mRNA vaccine. We know that. We've seen that the highest rates of myocarditis, pericarditis is among individuals 18 to 24 after the second dose. And we also recognize that rates following the Pfizer vaccine were significantly lower than after the Moderna vaccine. And this was felt to be dose related because the dose in the Moderna vaccine was much higher than the dose of the mRNA in the Pfizer vaccine. So this was felt to be dose related. So if you move now to the next slide, Brian, overall, looking at the surveillance data that have come out from the United States and from Israel, it really seems that the COVID-related myocarditis peaks among individuals who are older, and it declines in the 12 to 15. And we expect that it will decline further in the less than 12. And then we also recognize that the kids who are less than 12, the 5 to 11, will be getting a third of the dose. They'll be getting 10 micrograms. And so it would seem reasonable to predict that post-vaccine myocarditis rates are going to be lower in the 5 to less than 12 than one would see in the over 12s. And so I think that's a really key point that we need to remember moving into discussions with families. The expected lower rates of myocarditis in a setting where the dose is lower, and the lower dose, we believe, would be associated with a weaker signal. So two reasons for weaker signal: the lower age and the lower dose. And so I believe that, Brian, is my last slide. Can you just check? I think so. Yeah, thank you.
Thanks so much, Upton, for that really clear presentation. And I think really compelling data that you provided to us that help us to explain to our patients the risk of myocarditis and pericarditis and why we think it will be lower for children aged 5 to 11. So a really important concern we're hearing. I'm going to go now to a few questions that we've gotten in the Q&A while you've been speaking, Upton. So, you know, the top question really actually relates a little bit to this dose issue. For children turning 12 shortly, for example, January 2022, should they wait for the full dose vaccine or get it earlier with the lower dose? This is coming up with a lot of parents. And I guess we had a couple of questions about this. So the other question that someone put in related to that was, you know, suppose someone is 11 now and then almost 12 and they get their first dose, and then their second, you know, at the timing of their second dose, they actually would be 12. So there are many children, I guess, who fall in those kind of gray spots, and some of them may be high risk, for example. So what advice would you provide?
You know, that's a really brilliant question. We don't have the answer just yet, because I think that it's going to come down to policy versus the science. We know that vaccine responses through the pediatric age group tend to be related to immune maturity that is connected with age, as opposed to how big or small the kids are. So that's the first point, because we've gotten a version of that question that relates to, well, what about if my 11-year-old is tiny, or my 12-year-old is same body weight as a 10-year-old? What should I do? And so as far as the issue around weight, we really think that it's more a matter of maturity with age and not body weight. And so dosing, likely we don't want to do body weights, it's just too confusing. But what about the age range? What about the kids who are 11 turning 12, and 3, 4, 5 when the less than 5 vaccines become available? We don't know for sure yet. My own personal belief is that that's one of the things that NACI is looking at. I don't know for a fact, but I would guess that they're looking at that very carefully. I would prefer if kids who are close to the age cutoff get the lower dose. But somebody's going to ask, well, where is that cutoff? And we need to obviously make some policy around that. But I would prefer if they got a lower dose.
Yeah, thanks, Upton. I will say that I have a child turning 12 in February, and my husband and I had that same discussion. And I think we also thought that it would be absolutely fine to get that lower dose. I just posted in the chat what I thought was a good New York Times article related to that same question that you talked about. So the other set of questions, so another question that's come up, Upton, is there any feedback from other countries which already started younger kids' immunizations? Any known complications?
Yeah, the main complication that we are aware of in children of significance is the myocarditis, pericarditis signal. And most of the data are coming from Israel. And again, we're talking about individuals so far who are above 12. We don't have the data for the 5 to 11 just yet. And so that is the key signal. The other signals are the reactogenicity data. People have made, I've seen families who will come in with concerns. And what I would say to you, as I try to do, is when families ask you the question, is the vaccine safe? I think it might be good to just pause a little bit and try to see if you could understand what exactly they're referring to as safe. Because often families, when they think of safety, they think of, well, is this going to affect my child's kidneys and my child's liver and lung and heart in the years to come? And so I think the messaging can help to drill down on that, to let them know that as far as we know, we have no scientific reason to think that any of these vaccines will be affecting growth and development, ability of the kids to learn. Their heart is myocarditis, so we have that we are monitoring. The lung and liver, kidneys, no adverse events. So a more granular discussion of safety, I think, would be important. And then, of course, is the fertility question that comes up as well. And again, trying to let them know that there really is no scientific basis for that, and acknowledge where we think this all started, which is related to the effect on menstrual cycles, and try to explain how that is not connected with any concerns about reproduction and fertility.
Thanks, Upton. So the other question relates to this idea of COVID is less serious in kids. And so in particular, I think our audience is wondering, Is there any data on long haul COVID in kids? This concept has helped me convince many adults to get vaccinated. So that was Carolyn Donsky. And I think there was another question from Jennifer Tran about long COVID in kids as well, particularly wanting if there are any articles about it too.
Yeah, no, that's great. Thanks. I know Carolyn and Jennifer, those are really great questions. The data on, first of all, long COVID in kids, it's real. It does exist. We don't know the full extent of it yet. In the UK, the data suggests that it's probably about 4%, maybe overall in some studies, even lower, 2%. In Italy, 27%. So range, but we still don't really know the full extent of COVID, of long COVID. What we do know, Tara, is that the rates that you'll see reported will depend on a number of factors, including how long the children are followed for, whether or not they're assessed at 1 month, 3 months, 6 months. But there's another important point in trying to interpret the literature, Tara, and that is it's easier to detect long COVID signals, signs and symptoms among older individuals than the young kids. So when a young kid has brain fog, it might not come across as clearly in terms of the ability to detect as an older individual. And so we may want to bear that in mind, that it might well be that the rates of young COVID, long COVID in young children are underestimated rates.
Just a few more questions here, and then we'll turn to Sophie. So for younger kids, do we know yet whether other vaccines are going to be able to be given alongside it? So Runa Chowdhury said COVID vaccine can be given with no interval for other regular vaccines, e.g. Adacel, polio, MMR, flu shots, etc. Right? Is that true for younger kids too?
Yes, it'll be quite okay to give the COVID vaccine alongside other vaccines. They can be given at the same time. But all I would say is that from a scientific point of view, they can be given at the same time. You may want to just take into account some logistical issues. If you ask me personally, I would recognize the science, but if I can, give the COVID vaccine and create a little bit of space between them and the other vaccine, I would prefer that so that I can more accurately tell what is causing what. That's all. But from a scientific point of view, there's no reason why they couldn't be given together.
Thanks, Upton. So just maybe two more questions. So one from Kimberly Laville is about, do we have any information on immunization on the 6 months to 4 years group? Parents are waiting.
So that's a really great question. Yes, work is being done. What I'm told by, my spies is that we probably are looking at the first quarter of next year, but we don't know that for sure. But work is being done in that group.
Okay. And then Jenny Clement saying, what's the dose interval for kids recommended, given that it seems that the shorter interval of 21 days between Pfizer doses might reduce immunity? Do kids have the same issue, or do they have a better response as they are younger?
So that's a really great question. I think it's one of the important questions that NACI is addressing, because there's a question of not just immunogenicity, but whether or not there'll be any differences in terms of safety profiles if you separate the dosing intervals. So we have to hold off a little bit on until we see what NACI comes out with. we would expect that it would probably be somewhere in the 4 to 6 week time frame, but we don't know for sure just yet. We'll just have to wait and see.
Thank you. So I said last question, but I have one more that I feel like is important for you to address, Upton, before we go to Sophia. So Sandy Khan says, please address the rationale behind a mass immunization campaign for children, as they don't seem to be at high risk of serious illness, hospitalization, and death. Now that's, I think, a really key concern that some, or thought or perspective that some parents have as well, that kids are not at high risk of serious illness, hospitalization, and death. So you just gave that answer about long COVID, but perhaps you could also speak about that broader issue around why it's important to do this, even if kids don't have that high risk of serious illness, hospitalization.
Yeah, no, it's a really great question. I think it's important to recognize that, listen, we're still in a pandemic, and we're still at a pretty delicate stage. You just have to look at the uptick in the number of cases happening in parts of Europe, like Germany, for example, to recognize that we still can't relax the public health measures just yet, but soon, hopefully, we'll be able to do that. Kids, although they're not at risk of having severe disease to the extent to which adults do, they still can have serious illness from acute COVID. We know that they can have the multi-system inflammatory syndrome, and that, I've seen a number of cases. If you've managed any of those, it's frightening. I gotta tell you, it's frightening. Rare, but really frightening. And then third is the myocarditis. But then there's the impact of the public health measures plus vaccine and controlling the spread within schools, the home environment, sometimes with vulnerable family members around, and then the overall pandemic at a community level. And so we are still at this stage where we still need kids to contribute to that overall control at a public health level. I think your very first slide, I think, is a wonderful slide that shows that there's just one little piece missing. You remember that first slide you had up? And I think it's that, children and the ability to use measures such as vaccine and public health to control, that would help to complete the picture. But I think it's really important to recognize that we would like to get out of this soon, and I hope that it won't be much longer before we can relax some of the public health measures. We're just not there yet.
Yeah, thanks, Upton. So I think there's benefits to the individual person as well as benefits to our community. And I think although we're doing well here in Ontario, and I see some of those Q&A around that, we can look to other jurisdictions that are in different circumstances, and we can be vulnerable to that as well. And I think Upton's made some great points about missed school, isolation. Like, there are lots of impacts, even if you have mild illness as well.
Yeah. Tara, there's one other point I just want to mention, and that is when we look at COVID, across a province like Ontario, we're dealing with a number of different worlds. And I know Sophia will speak to this. When you look at some of the high risk hot zone communities, COVID rates in those communities are extremely high, and you can see the impact and importance of public health measures in those areas. So I know it's not a one size fit all, but one has to recognize that for some communities, in particular Indigenous and racialized communities, we're not at a point yet where we can totally relax on all the public health measures, including the mask strategies.
I think that's a terrific segue to Sophie's section. And just, Brian, as you're getting Sophie's slides up, I'm just going to read this response in the chat from Vicky Chen, who I think summed it up really nicely as well. She said, we should remember that individually, we are not at high risk of contracting or dying from the diseases prevented by our routine immunizations. However, if immunization rates fall, then these diseases reappear and pose a threat to the population. So yeah, thank you, Vicky, for just reminding us of what we know, but I think COVID has kind of taken it out of a different context for so many of us. So thank you. So Sophie, you and your team have been doing some incredible work with communities, particularly communities that have been hard hit by COVID, and really trying to understand their perspectives. And our jobs as family doctors is to understand those perspectives, to meet people where they're at, and hopefully help to move that needle, to help them, literally move that needle, I guess, into their arm to a point where they're interested in getting that vaccine. So I'm looking forward to hearing from you and Nolan about what you've heard to date.
Great, thanks, Tara. If you can just skip ahead a couple of slides. We're really excited to share some of the things that we heard from the field. So we had the opportunity to speak to about 60 people in the last couple of weeks, parents and community ambassadors. And I think Upton and Tara have given a really good overview of the evidence and also many of the reasons cited by parents who are ready for their children to have the vaccine. We were curious about the experience of parents in the communities we've been working in. So these are the hardest hit communities in terms of COVID rates. They're also most marginalized because of their rates of racialization and also their low income. And so it's important, I think, to balance against what we know many parents are ready to do with, I think, the voices of those who still have many questions. So just a quick overview. I'm going to ask you to the next slide. These are our general themes that we found. First, I think in these communities in particular, parents have not moved on. So we did hear quite a bit of frustration and fatigue. And that is really very much the backdrop that most parents are making this decision in. In the communities that we were speaking with people, many of those impacts are still differentially felt. So the gap is bigger for them. And of course, that means that ending the pandemic is a meaningful motivator, but it also means that their experience and their trust has very much been eroded by their experience. So that's, I think, the first important point. The second is that we heard from parents a general sense of frustration around their ability to get access to information and really properly balance a lot of conflicting information that they're receiving. They want proof that the vaccines are making a difference, and they also want reassurances around the side effects. And then finally, we heard a lot about where the trusted relationships sit. So while there is a baseline mistrust in some of these communities of overall institutions, there are very high rates of trust for family doctors, teachers, and educators. So we can just skip ahead. The next slide. This just gives you a bit of a picture of where we were in these consultations. So like I said, we spoke to over 60 people. The majority of our consultations were in the GTA. These are the communities that we've been working with through the High Priority Initiative. We spoke with folks from Hispanic, African, Black, Caribbean, Arab, Kiran, Middle Eastern, Lebanese, Indian, and South Indian communities. So just going to give you a little bit more color, but you'll have a takeaway on direct quotes from parents and themes. So if we can just skip ahead 2 slides, please. I think the first, I think what we were met with initially was this message, which is in these communities in particular, where people have felt that there have been many asks of them. This ask feels like yet another request from people who have struggled during the pandemic. And there's some baseline frustration. I know many parents have said, we took the vaccine, we did it to protect our children, we're not ready to put our kids through the same. And so I think it's important to know that that's context for many individuals. In addition to that, I think the introduction of mandates has created a sense of pressure. If we go to the next slide, please. That parents are feeling, and they do have a real fear around the impact of potential mandates on their children. Many of them ask questions around whether or not their kids would be excluded from activities. And in the communities where we're speaking, the impact of removing kids from the opportunity for extracurricular does go a little bit further. If we can go to the next slide, please. There's a recognition that the vaccine is not a panacea. So while we know that it is going to help to speed the end of the pandemic and the public health measures, it's not a panacea in terms of ending those. And parents are keenly aware of that. So the message has to be balanced against vaccine plus ongoing efforts to keep people safe. And parents were looking to teachers and schools and government to ensure that everything else is being done. If they're going to have their children vaccinated, they want to see equal effort across other partners. There is a general mistrust of institutions, and that remains true in these conversations. I think the introduction of vaccine mandates has harmed trust in some of these communities where people are facing the loss of income. And so it is important to recognize that while the mandates have been really effective in advancing vaccination rates, that plus tactics and shifting messaging, the broader policy context, are all sort of coming together to reinforce some of that baseline mistrust. One bright spot that we did here was that for many parents who immigrated to Canada, if we can go to the next slide, please, and then the next slide after that. For many parents who've immigrated to Canada, there is a positive perception of the Canadian healthcare system. So if you can, as a family doctor in your conversations, invoke that mindset, it really is helpful for people to be reminded that they can trust our system. So if you can go to the next slide, please. These are just some general takeaways. I think the context is important just to remind us that the conversation is really delicate. So as you're entering into these discussions, the most important thing that we're saying to community ambassadors and to clinicians is to take your time and ensure that you're not running the risk of a further entrenching a no. So in any moment when a parent feels like they have to defend their position or their worldview is being interrogated, you run the risk of pushing them further into an answer of no. I think it's also important to acknowledge that there's an opportunity for schools and doctors to come together around giving proper information to parents. If we can go to the next slide, please. This is just basic informational needs. So Dr. Allen covered many of these things, but this is the way it sounds when it comes from parents. First, parents really want to have some validation that getting vaccinated themselves had an impact on COVID rates and that it will be the right choice for their children. Next slide, please. They also, of course, have many questions about the long-term impacts, and Dr. Allen spoke to the evidence around that, but this is top of mind for parents, the uncertainty about side effects and the additional protocols that may be still required to keep kids safe are coming together to make parents feel uncomfortable. We can go to the next slide. Generally speaking, what we heard from parents is that they feel capable of making an informed decision as long as the information that's provided to them is presented in a neutral and transparent way. Any opportunity that we can to normalize changes in advice or shifting messaging, just to consistently explain to them why those changes are being made so they're not being perceived as inconsistencies or mistakes, is key. Also finding ways to convey information about the benefits and risks of the vaccine versus risks of COVID for children in a balanced way is important. I think their critique of any information that comes to them in a coercive or in a manner that seems to be trying to convince them, I think really heightens their concerns around what that conversation is tracking towards. So I'm just going to skip ahead through trusted relationships. Brian, if you can go directly to the slide related to healthcare providers and parents and family doctors. So we did hear, generally speaking, there's a very high level of trust in family physicians. In fact, most parents felt that the decision to get the vaccine and the delivery of the vaccine should happen with the family doctor in the mix, either delivering the vaccine or the conversation. They see family doctors as really credible sources of information, and they trust that relationship deeply. If we can go to the next slide, please. The information that we have been providing to the province, to the government around this, is to consider ways in which we can integrate family physicians into the mix, both on the teaching side of the house and also on the delivery side. So we did hear in the logistics aspect, if you can skip ahead to the next, there was an interest in family doctors' offices delivering the vaccine or family physicians potentially being present. If you can just go to the next slide, please. And also potentially having family physicians involved in the conversation that might happen in schools. So understanding that teachers are most likely to be getting many of these questions just because it's a high touch point. any opportunity to skill teachers and educators up around the basic information on the COVID vaccine would be very helpful. This last slide that I wanted to share is just general tips around how to have proactive conversations and productive conversations with families. So of course, all family doctors are really skilled in the area of motivational interviewing. I think this slide is just there to remind you that for many parents, it will be multiple touch points with you, asking questions. It may be a longer decision trajectory as they gather information and try and make sense of it. So the opportunity to keep the conversation as open as possible, really ensuring that we're not ending up entrenching resistance or people's fears. And so I'll just stop there. Embedded in the slide deck, we also have on the next slide, you can see a link to our other tools that are related to ensuring fair access to vaccines, particularly in the communities we've been working in.
Thanks so much, Sophie. Such incredible work that your team has done going into these high-risk communities and really trying to understand their perspectives. And I really appreciate that you've highlighted the trust they feel in family doctors and the role that we have to play. Obviously, we're all getting ready today to counsel our patients effectively and have those conversations, which is part of it. But I also heard from you that they want us to be involved in the delivery. And so we're not focusing today on the delivery, but in future sessions, we will be talking about that. You know, what are some of the things we need to consider when specifically setting up clinics in our offices for children 5 to 11, for those of us who feel that we can deliver the vaccine in our clinics. But then even if we are partnering with schools, which I hope we are, you know, having a family doctor there can make a big difference. And I know some doctors, infectious disease specialists, are already now setting up town halls and conversations with parents in their local school communities. And I hope that these are things that you guys are all thinking about as well. So thank you. I'm going to just share a few quick resources and then go to some questions. So next slide, Brian. This has come up in the chat. I think Kimberly Miranda has posted about this, but I wanted to just highlight that this is an excellent website, Kids Health First, that has terrific information on vaccines in kids. It is parent and kid facing, so it's meant for them, but of course for you, it has great information that you can convey to your patients. Next slide. Then we also know that, you know, a big piece for kids is making them feel comfortable with the vaccination. So 5 to 11-year-olds in particular, there can be fear and anxiety around needles. And so this card model is one that's been adopted nationally as an approach for really supporting patients to feel comfortable getting vaccinated. And so there's lots of resources, posters, handouts, etc. On the Immunize Canada website, another great website for immunization about this card model. Next slide. I wanted to remind you guys about the Vax Facts clinic. We had Latif Morji here last time, and he also emphasized, just like Sophie, the importance of motivational interviewing. So if you missed that conversation, please go back and watch one session ago, so 2 weeks ago. At the end of the session, he gave a talk on their approach to getting that last mile vaccinated. And a lot of it did rest with that open, curious type of questions that will go along with motivational interviewing. Next slide. And then, you know, right now, for those who's 12 to 17, there is a terrific service that Sick Kids is offering for addressing parents' concerns around vaccines. So again, a terrific resource, and I suspect it'll be expanded once vaccines to 5 to 11-year-olds get it approved here. So I think those were the main resource slides, and you can stop slides for a moment there, Brian. What I'm going to do is just go to some of our questions. I'm going to pivot to a question that's not at all related to children age 5 to 11, but rather is related to booster doses, because it is actually got 60 people gave it a thumbs up. And Upton, I'm going to ask, I don't know if you're going to be able to answer this question, but we'll pose it to you. And if you don't feel you have the expertise, what we'll do is we'll turn to one of our experts and answer it following the session. So Carrie Bernard asks, I'm hearing that it's better to get a Moderna booster if you had a double vaccination of Pfizer. So this is for adult population. If you got 2 doses of Pfizer, is it better to get a Moderna booster than get the 3rd dose being Pfizer? I don't know if this is something you can answer, Upton. I don't think Liz and I have an answer to that.
Yeah, I can't see any real scientific basis for that type of assumption. No, I don't. The Moderna booster would be at a higher dose unless one makes unless a decision is made to actually have it, which there's been some discussion around that. But I think that we're still awaiting the full guidance on the booster doses, but I don't see any particular reason to think that rather than having a Pfizer booster, Moderna booster would be the way to go. No, I don't.
Thanks, Upton. So, well, I appreciate that. So just, a few things that have popped up in response to our discussion here. I think Kimberly Wintemute asked if teens and preteens can call Vax Facts, and I think they can. They are an eligible population right now, so I think they can. Yes, you do get CME for this talk. And also, I mean, I think this, there's a lot of information here that we've shared that is going to be potentially relevant to colleagues of yours who couldn't attend. So just wanted to highlight that the recording of this session will likely be available even just later today. So our team is going to work hard to put it up on our website, and Leanne is posted the website in the chat. So please do check out that website and point colleagues to the website, and actually watching the video after the fact is MainPro accredited as well. So so lots of reasons to share this really informational session with others. I think Carrie is saying the half-dose Moderna for boosters under age 70 is the current recommendation. And Nicola says the similar thing, the Moderna booster for those age 70 and younger is half the primary series. I don't know if that changes your answer, Upton.
No, I think, yeah, you're right. There's discussion around using a lower dose of the Moderna, but I can't see any scientific reason to think that boosting with Moderna would provide any advantage with respect to immunogenicity over Pfizer boosting.
Okay.
I think where the difference is as indicated in the guidance that's been issued, is if you got AstraZeneca before, then you boost with an mRNA. But at half the dose or standard dose, I can't see any scientific reason for a difference.
Okay. Liz, I'm wondering if there's anything that you wanted to add based on your observations of the session and some of the questions you've been answering.
Yeah, so I mean, lots of questions about the boosters that I was putting in, including the guidance around, as we were just saying, around the who should get the half dose and who shouldn't. And so, which is something that applies to the older population, obviously, right now, and really emphasizing that it's a 6-month interval at this point, and that's based on the efficacy data that we're seeing. I, can hazard some guess, but I don't have the evidence to, tell you what did the Moderna trials show specifically on efficacy of the half dose versus the full dose, but that was what they submitted. So I think that's a great question for us to take away specifically, and we can get that for you. There were a few questions about vaccines and how they're going to be disseminated. I can tell you that every single public health unit across the province has already submitted their plan to the ministry for how they're going to distribute the vaccines. Public health units are going to play a very key role. They have all been asked to include at least one school so that their vaccines are available in a school or near a school. I expect we're going to see many schools. So the use of sort of vaccination in a school-based setting. Lots of Obviously, pharmacies will also be involved. We've been encouraged as family doctors to be involved. So if this is something you want to do, recognizing that not every office can do this, but if you think this is something you want to do and can do, please do reach out to your public health unit. If you don't know who to reach out to, you can email us. We'll connect you with the right person. So you are welcome to participate in that giving vaccines in office, in addition to all of the work that I know you're doing around just counseling patients, which we talked a lot about today. So those would just be a few things to add.
Thanks, Liz. So I know that that's, it's going to require a collaborative effort once more. So it's us as family doctors working with public health and with pharmacists, pediatricians, community ambassadors and community organizations and others. Again, I think a lot of us are tired and focused on COVID recovery, but I know all of you are also excited to get this sort of second last population vaccinated to get us closer to ending this pandemic. Brian, are you able to bring up the practicing well slide? I mentioned that so many of us are feeling, burned out and tired, and I just wanted to highlight this session that's happening with another community of practice or co-organized by the Department of Family Medicine and the OCFP. This session on November 10th is, I think, the second session they're having on burnout. So please do, sign up for that. Next slide. And as usual, I just wanted to thank all of our panelists who took the time to come today to read your questions, prepare for them, and answer them within the session. I know that this is a session that's going to be watched by many, even after the fact. So thank you to all of our panelists. Thank you to the audience members who've been engaging and sharing and asking questions throughout. We've put the link in the chat around where you can access the session after the fact. So if you want to share it with colleagues, again, this is MainPro accredited. Whether you watch it live or whether you watch it after the fact, it's both MainPro. It's a MainPro accredited for both. We'll also be posting the terrific slides. I know Sophie's slide deck had a lot of great detail that she had to skim over because of time, but there's some, I think, really poignant quotes in there, and I hope you'll take a moment to go take a look at that. And similarly, Dr. Upton had some terrific sort of slides that he had around myocarditis, pericarditis that's going to be really helpful for us as we counsel our patients. So thank you to Upton Allen, Sophia, Ikura, to all of you. And we'll see you at our next session, November 19th. Please do fill out our evaluation and let us know what you want us to have for that next session. In the meantime, take care and thanks for all you're doing.